So I'm going to be chatting about transitioning from inpatient or hospitalized hospital setting for PCNL to outpatient. So outpatient can encompass two different areas. We can talk about outpatient in the hospital where a patient comes in, has a procedure. You have the option to observe them overnight, or you can send them home the same day. Uh, Once you get comfortable with that, then you can start to consider, again, I think only with, and we'll go over this, only with a very skilled team and a seasoned team could you then consider um, perhaps shifting your PCNL practice to a true outpatient setting in an ambulatory setting. So, the first PCNL, certainly this is not a new procedure. The procedure was performed in 1976. I think when we talk about standard PCNL, we kind of look at what was done in the 1980s as the standardized approach, which is IR obtains the access. These are done in a hospital setting. We use nephrostomy tubes, in many cases, very large tubes. And then I think generally that is probably the step that led to hospitalization. Generally, of course, there are other considerations in terms of the risk associated with the procedure. But I think that when we talk about PCNL, we have to kind of understand that there's historically maybe the 1980s PCNLs and to what we can do today. And I think this talk in particular, this topic about the MIP system and the mini PCNL, which is the MIP-M system, really lends itself to considering outpatient surgery. Right there. So the first publication for an outpatient PCNL actually came from Darren Bako back in 2009, and then he published a series in 2010. I had just kind of started into my higher volume PCNL practice around that time. And I, seeing these publications kind of piqued my interest into the possibility of transitioning PCNL to an outpatient setting. Dr. Abbott and I reported our first case report back in 2017, but we started doing outpatient cases really back in 2011, 2012, and our first ASC cases in 2015. So we have about 5 years under our belt. And then, of course, Dr. Sir and Seth, Dr. Beaches have published their series a couple years ago. Next slide. So I have some recommendations, a little bit of transition planning, and then specifically talking about, how MIP will sort of really fits nicely into this kind of thinking. So again, my recommendations are you do want to have high case volumes before you consider at least an ambulatory setting. Even an outpatient setting, I think in a hospital is something that you would want to have, a fair amount of experience under your belt before you really you try this. In some cases, I've talked to groups where there's multiple physicians performing PCNL. I agree that we want to make this an inclusive thing where many can do this, but I think early on you want to have high volume centers and high volume teams. Most of my OR team has performed over 1,000 PCNLs with me. Some of them over 1,500 now, and we use the same anesthesiologists. We use the same C-arm techs, so it really makes for a very kind of like a well-oiled machine, if you will. And that's really the kind of setup you want before you start to consider moving anything like this to an outpatient or certainly an ambulatory setting. Next slide. So when you look at transition planning, there's clinical, operational, and financial. And I think that's true of almost any program. You can't really have, if one of these fails, then you're not going to be able to move a program forward. Next slide. Clinically, next slide, Jamie. Clinically, we look at, next slide, thanks. So this gets asked a lot, who are patients that can be done in an outpatient setting and which patients are ones that cannot be. 5 years ago, I would have had, this list would have looked a little bit different. In other words, I would have had, I think, a lot more defined characteristics as to what can or can't be done in an outpatient setting. Today, what I would say is that really with the more experience that you gain, the thing that really keeps you from doing this as an outpatient is going to be the medical stuff. So it's not really going to be stone burden. It's not going to necessarily be stone location or density or perirenal anatomy. These are things you have to consider. But once you gain enough experience with this, we've taken care of staghorn stones in the ASC. We've taken care of multiple diverticular stones in the ASC. We've done multiple tracks. We've done, super or subcostal access. So, but in the beginning, you of course want to take on, I think again, the MIP system, the MIP-M system fits nicely here because in that 10 to 20 millimeter stone size, that tends to be a more straightforward mini PCNL, I think that one is a great one to choose for an outpatient or ASC setting. But today, the things that limit us are major cardiac and pulmonary issues. BMIs above 40 can be tough. Above 50 are basically an absolute no. Then I would caution you about the other three on the list. If a patient has chronic pain, you really want to be, thinking about the fact that you may not want to do them in an ambulatory setting, even if they have a straightforward case in your mind. Otherwise, infection risk. If you really suspect that a patient may need IV antibiotics beyond just a single dose that you're able to give in an ambulatory setting or a couple doses, that's somebody you may want to take to the hospital. And then, of course, bleeding risk. So if anybody has a bleeding risk, clearly those are cases you would not want to be, out on a limb there trying to take care of an issue like that in a place that would be difficult to do so. Next slide. So clinically, I think the main things that I sort of drive home are you want urologists obtain renal access. I'm a big proponent of that. Roger gave a great talk on using ultrasound. I think whatever technique you use, if you get good at it and you get efficient at it, the thing I tell everybody is make sure you have great access. I think we can all agree that if you have great access, you're going to have a great case. Again, if you want to think about an ambulatory setting, particularly a true ASC that's freestanding, 100% you need to do a lot of outpatient cases in a hospital setting first. I would say between 50 and 100. And what I would recommend is that you actually try to predict before you do the case who's going to go home and who's not. And then you track your results, because once you get to an ambulatory setting, an ASC, if you're wrong, that means you're going to be transferring patients via an ambulance most of the time. And that's something you want to try to minimize. And then again, pain management. We now start with pain management and nausea management even before they hit the door almost, because that's going to be the things that would really tie you up. And again, in a true ambulatory setting where you may not have as much ability to watch patients or keep patients or a large number of patients for extended stays or overnight stays. Next slide. Post-procedurally, I think, you want to give patients as much information as you can, set expectations. What I found that was kind of incredible was that once a patient knew they were doing this as an outpatient or in an ambulatory setting, it's like their whole mindset changes, much like I think the surgeon's mindset may change. So they sort of come in with the expectation that they're going to, have a procedure. Yes, it's going to be uncomfortable and painful as many, as any OR case may be, any surgical procedure. I joke with my patients, I have yet to figure out how to do painless PCNL, but I'm working on it. And so if you can set those expectations, as we talked about, as Seth mentioned, the MIP system really lends itself to being tubeless. As Sri mentioned, totally tubeless is even better. The less drains patients have post-op, the less pain they're going to have post-op. Of course, you have to be selective about how you do that and how you approach it. But I think that minimizing drainage tubes is something that this MIP system really lends itself to, and I'm a big advocate of that. And then, I have a cocktail of medications and instructions I give patients, which I think is also important to have all that set up. Next slide. So operationally, I think you need to think about the infrastructure, particularly if you're going to be building an ASC or moving into an ASC. There's certainly equipment and technology, your OR setup, what disposals you may need. But then the thing I really highlight is workflow. If you have a good workflow down, then you're going to be able to transition through your day much better. We can do about 4 of these in a day and be done by 4 p.m. So 4 by 4 is our goal. 4 PCNLs by 4 p.m. I'm not saying we pull it off every single time, but we pull it off with pretty consistent results. And that has a lot to do with your workflow, both from the pre-op and clearance and patient selection, all the way through how you register the patient, how they come through the pre-op area, how your OR team kind of functions, number of scope sets you have, many things to consider to get that workflow optimized. Next slide. So your infrastructure, I personally think having a nice sizable room is helpful. I've done these in what I call closet ORs before. Means, you can do these anywhere, but I think if you have a good sized room, it does sort of allow for a greater efficiency of equipment kind of moving out of the way, but not necessarily out of the room, and then patients in and out of the room a little bit quicker. As I mentioned before, you want to have a good pre-op area, good adequate PACU beds, and you want to really consider, again, in a true ASC, are you going to be keeping patients overnight or not? In our practice, we opted to, we actually weren't allowed to keep patients overnight, even though the federal law allowed it, or the Maryland state law didn't. So in some ways, I think the ASC PCNL program took off because of the fact that I wasn't able to keep them overnight. I think if I was given that option 5 years ago, if the state of Maryland had said you can keep your patients overnight, I would have done it. But because they said you couldn't, and we wanted to sort of move in this direction, we kind of slowly tiptoed in that direction, and it worked out. Our average PACU time is just a little bit over 90 minutes now. So it's incredible how you can watch these patients. And I think, and we're not discharging them inappropriately. They meet all parameters for discharge, generally within 80 to 100 minutes. And some patients can meet the discharge criteria even faster. Next slide. Let's just keep going. So there's a lot of equipment and technology. I want to keep my eye on time here. So let's just keep moving forward. So, you've seen, I think, at least one other picture of an OR setup. I had to use this panoramic to get the whole OR equipment in there. And that's just kind of the point of this. I'm happy to share our setup with anybody who wants it. But the bottom line is that you've just got a lot of equipment, a lot of stuff. And I think the more that you can manage a system that works for you, a way you can get a patient in and out without having to really kind of, redo the room every time is, I think, helpful. Next slide. And this is really what I alluded to earlier. So the workflow, it starts with preoperative. It starts with patient selection and knowing what things to look for, asking the right questions. I've asked patients before if they have any heart or lung issues, even though their history says it's negative. Then they'll say, oh, somebody told me I had sleep apnea once and I never got it looked into. And that's something that on the day of the procedure, if that comes up, that may be something the anesthesiologist doesn't want to move forward in, especially in an ASC setting. Your check-in process, again, as I already mentioned, the OR setup, instrumentation. So again, one nice thing about the MIP system and the MIP-M, as I think is the sweet spot, is that you've got reusable equipment, you've got low cost of capital cost, and again, you want to have multiple sets if you're looking to create an efficient system. Backup equipment, we have at least 2 lasers. Again, that can get expensive, but you don't really want to be caught without a backup. And then developing good discharge criteria and just having experienced even a PACU team, not just necessarily experienced OR team or surgeon, but even in the PACU, you want to have good nurses that really have dealt with a little bit more higher acuity patients so that they can really manage your patients appropriately. Next slide. So I'll just talk a little bit about financial. I think it's safe to say that in most payer mixes, Medicare comprises about 25%. Again, this is just a general average. This is not a specific. That means the commercial takes up about 75%. So one thing about kidney stones is that they don't affect patients over age 65, like many of the urology conditions like BPH might or OAB. So you've got kind of a full spectrum of patients. That means you've got a good number of patients that are in their 30s and 40s and 50s who may have better commercial insurance, and this can be to your benefit, especially if you're looking at a program where you're financially on the hook for this. Next slide. So you wanted to, with any financial plan, you want to determine your fixed costs. You want to track variable costs, and that's going to give you a pretty simple equation to determine profitability. Next slide. So again, back to the MIP system. The nice thing about MIP is that it is a PCNL. So it is not a different CPT code. We're not reinventing the wheel here. You can use the very same codes that are used in the hospital in your surgery center setting. It depends on the stone burden, under or over 20 millimeters. While it's true that the MIP system may lend itself to the 10 to 20 millimeter stone size, we have used it on stones up to 30, 35 millimeters very effectively. And I would say that a good number of our mini perks and our MIP-M PCNLs are 50081 cases. At least where I am, again, none of this is, all these comments about coding and financial is going to be very different from state to state and region to region, and certainly in different countries, this may not apply at all. But, at least even though the 81 and 80 code may reimburse differently from a professional fee, we find that we get the same facility fees for both. So that's actually very nice because if you've got a system like MIP-M where you can reuse much of the equipment, you're still going to get paid the same whether you're doing a smaller stone or a larger stone. But the other take-home message is you got to negotiate your rates, and if you're in a large enough group, or if your group has enough of a presence, then you are able to kind of go to the commercial carriers and say, look, we do it for about 30% less than the hospital, and so that's made it attractive for all the commercial carriers to want us to do these in a surgery center. Last week I had to get on 2. This is a negative, a word of caution. Last week I had to get on 2 calls to sort of tell these insurance companies why I can't do it in the surgery center. So once you start doing these in the surgery center, they're going to want everybody done there, even the sicker patients. But you just have to take the time to tell them, look, we can't do everybody there. There are certain cardiac, pulmonary issues, BMI issues where that's not going to be. You're not going to be able to do this in an outpatient setting. Next slide. And that's it. That's all I got. I tried to kind of speed through that to get us caught up a little bit. I know we're over time, but I think I'll turn it back over to Roger, our MC. Thank you.
Great, thank you, Julio, Shri, and Seth. Julio, I got a quick question for you. Could you just recap, if someone wanted to start doing outpatient PCNLs, what would be a good starter patient, or can you summarize the criteria?
Yeah, so great question, Roger. So, backing up to 2015, the very first patient I operated on was a patient on whom I had done a contralateral procedure at the hospital, and he had done great. And so he was an ideal patient to take to an ambulatory setting because I was doing the opposite side. He knew his outcomes. But I sort of say that as a preface. So you want to pick a patient that passes the eyeball test. So you're not too worried about them having pain issues. They're not too skinny, not too fat. I think all of us know that patients that are very, very thin can sometimes be a challenge as well for PCNL because of the access and the hypermobile kidney. So, patients who are kind of medium sized, no heart or lung issues. So medically a good candidate. And then I would, obviously, like if you can pick a 15 millimeter renal pelvis stone, I think that's a great case to start with. Again, start out simple and then increase complexity. I will say this, and Sri talked about it. When you're looking at these cases that are between 10 and 20 millimeters, you can do them ureteroscopically. But what I find, and what we're sort of trying to show with some of the data that we're collecting, is that we just get better outcomes with the mini PCNL, with the MIP-M. We're able to make them stone free. We're able to still send them home the same day. You can, again, consider no tubes at all, or just a stent, which is the same as a ureteroscopy. We can take stents out within 48 hours. So I think there are many advantages, but you have to have that level of comfort with doing PCNL in general, and then doing transitioning to a mini. And I think it really lends itself to this outpatient setting. But keep it simple. Avoid large BMIs. Avoid complex patients medically or surgically in the beginning. Once you've got 10 or 15 patients under your belt, then you can kind of start, to expand your criteria. If you look back at the first 25 I did, I'm sure that they were all, just the most ideal candidates. And it took me a year to do 25 cases. So, we do 25 a month now, but in the beginning, it was a year to do 25 ASC cases.